Thank you, ma'am. Presenting a case of short stature, which is a common cause of referral to genetics to exclude syndromic or the skeletal etiology. So we all know that with availability of genomic testing, it is possible to diagnose rare novel phenotypes. However, genomic findings often needs functional validation, which is possible in an institute like ours with a fantastic collaborative department. So this CCR is basically representing the collective work of all the various departments that have been involved in solving and validating this case. So with this, I will hand over to our DM, Dr. Somalia, who has recently cleared his DM.
Thank you, ma'am. Good afternoon, everyone. So we'll be starting the presentation. So we will be seeing 3 cases which had presented with short stature to our pediatrics department. The first family was a third-degree consanguineously married couple. They had presented with 2 siblings. The first child was a 5-year-old female. She had presented with chief complaints of inadequate weight gain, short stature, recurrent diarrhea since infancy, and mild developmental delay. She was a low birth weight baby and had an uneventful neonatal course. The other child from the same family was a 1-month-old younger brother. He had also presented with complaints of poor weight gain since birth, and he had moderate intellectual disability at 11 months of age. On examination, the first child, she had failure to thrive with short stature and microcephaly and had a high-pitched voice. So both of the children were dysmorphic, and on examination we found that both had a high forehead, triangular face, flat occiput with dilated veins, small palpebral fissures as we can see, a high arched palate, thin vermilion of the lips, short nose and dysplastic locate ears. The second child also had failure to thrive. In addition, the first child had right hypoplastic thumb, clinodactyly and bilateral sandal clap in the foot. Coming on to our third case, this was a 3-year-old girl. She had also presented with failure to thrive with normal development. She was also a low birth weight baby. On examination, had failure to thrive with short stature and microcephaly. She was also dysmorphic. On examination, she had a triangular face, deep set eyes, hypertelorism, big nose, and a smooth philtrum. She also had limb abnormalities. She had a broad wrist, broad proximally placed bilateral thumb, as we can see, brachydactyly, tapering fingers, and clinodactyly. And in her lower limb, she had hallux varus, brachydactyly with medial rotation of both the toes, and second and third toes clinodactyly and syndactyly, as we can see. So in a common database, we have 3 children who had presented with failure to thrive with a common pattern of dysmorphism in the form of triangular face, narrow palpebral fissures, micrognathia, rhizomelia, with some atypical features in two children. One had a thumb hypoplasia and the other child had a syndactyly with brachydactyly with mild to moderate developmental delay. So possibility of a syndromic primordial short stature was kept clinically in all these 3 cases. Since the children had presented with short stature, we got some radiological investigations done in these children, and I would invite Dr. Anjali Shah, Senior Resident, Department of Radiology, for discussing the radiological findings.
Good afternoon, everyone. I'm Dr. Anjali, Senior Resident in Department of Radiodiagnosis, and I will be presenting the imaging findings of these cases. So in case 1, the skull X-ray shows enlarged void with a narrow base and thinning of the occipital bone. Bilateral hand X-ray shows hypoplastic right thumb and absence of the first metacarpal bone. The bone age is around 2 to 3 years of age. In the cross-section CT images, we can see there is caudal herniation with towering of the cerebellar tonsils around the brainstem and associated mild ventriculomegaly. Similarly, in case 2 also, the MR images shows small posterior fossa and towering of the cerebellar tonsils around the brainstem. In addition, there are multiple intradiploid herniation of brain parenchyma in the occipital region consisting with intradiploid encephalocele. The NCCT bone window images shows poor ossification of the occipital bone along with multiple intradiploid brain herniation. In case 3, we can see that in bilateral hands, the bone age is around 2 years. In bilateral knee joint X-ray, there is absence of bilateral patellar bone. And in foot X-ray, there is coning of the distal epiphysis and short, square-shaped proximal phalanx of bilateral first digits. So to summarize the findings, there is shallow occipital bone in both the patients of family 1, indicating a small posterior fossa. There is herniation of cerebellar tonsils, prominence of convolutional markings over the occipital bone, along with intradiploid herniation of brain parenchyma in the occipital bone.
Thank you, ma'am. So we did further workup for these 3 children, and we found that the echo and the ultrasound abdomen was normal. In family 1, for the first child, chromosomal microarray was done because she had short stature with dysmorphism and developmental delay, which was also not suggestive of any pathogenic CNP. So we went ahead and did exome sequencing in these 2 families. In the first family, we got a 5' splice site donor variant in the CEP57 gene, which was positive of Mosaic variegated aneuploidy syndrome type 2. This was a homozygous novel variant and was pathogenic according to the ACMG criteria. In the second family, we found a large deletion which involved exons 5 to 8, as we can see in this integrated genome viewer snapshot of the exome of the NGS data. So in this we can see that in the control sample we have reads for exon 5 to 8, whereas in the patient sample we have no reads, which was suggestive of a deletion involving these exons. And this was also a pathogenic variant according to the ACMG classification and was a novel finding. So coming on to mosaic variegated aneuploidy syndrome, the MVAs are a group of syndromes which are characterized by defects in the cell division with predisposition to aneuploidy. Up till now, around 6 genes have been implicated which cause MVA, and most of these genes are involved in the mitotic spindle formation, microtubule stabilization, and spindle assembly checkpoint. So the presence of constitutional mosaic aneuploidy is due to gain or loss of multiple different chromosomes is hallmark of all these MVA syndromes. Premature separation of the sister chromatids occurs during the mitosis and leads to these aneuploidies. Predisposition to neoplasms has been found in some types of MVA, namely MVA1 and MVA3. However, it has not yet been reported for MVA type 2. Till now, 16 individuals from 13 families have been described of harboring mutations causative for mosaic variegated aneuploidy syndrome type 2. So, what is the pathophysiology of the disease? So, during mitotic spindle formation, the CEP57 protein, it associates with the pericentrin protein, and this engages the mother and the daughter centriole. This occurs during the normal mitosis. However, in case of CEP57 mutations resulting in loss of function, this association between the pericentrin and the CEP57 protein does not occur. This leads to the pericentriolar material disorganization and precocious disengagement of the mother and the daughter centriole, as we can see here. This in turn leads to ectopic mitotic organization centered activity and aberrant acquisition of pericentriolar material in the cells. This in turn leads to unequal distribution of centrioles, multipolar spindles, chromosome misalignment, and ultimately resulting in chromosome lagging and aneuploidy. We did karyotype in these 3 patients, and we found that in all the 3 cases there was variable level of aneuploidies, which was not fixed for any particular chromosome, and all these 3 individuals were mosaic for these aneuploidies. As we can see, in case 1 it was 34%, in the case 2 it was 31%, and in case 3 it was around 5%. Since these variants were novel variants which have not been earlier described, we went ahead and did the functional analysis for the mutant CEP57 variants. So Ms. Sumedha, Dr. Preeti from Department of Biochemistry, and Dr. Ayatullah from Department of Biophysics will be discussing the functional analysis.
Good afternoon, everyone. Since the exome sequencing data has already revealed that the mutant that we have is having a 5' donor splice site mutation, let us quickly touch upon what is the basic mechanism of splicing. Splicing is basically a process that is involved in the removal of these non-coding intron sequences and joining of these 5 exome sequences which are to produce a mature mRNA. Herein, the canonical 5' and 3' splice sites along with the branch point in the premature mRNA undergoes 2 trans-esterification reactions in order to produce an intron lavate and production of these mature mRNA with the spliced exons. Any mutations in this 5', 3' splice site or in the branch point can lead to a variety of variants in the that is leading to abnormal transcript production. So there are multiple types of splicing mutations as we have seen, but looking at the data that we have got from exome sequencing, our case study is actually belonging to the class 1 type of splicing mutation, wherein there is a mutation at the 5' splice site which can further lead to or expected to cause a skipping of an exon leading to production of an abnormal transcript. So, in order to identify the splicer, what will be the result of this kind of a splice site mutation? We have done in silico analysis with the splice site prediction tools, and herein, as we can see here, that the point mutation at the 5' donor splice site has predicted a loss of function for authentic splice site, which can further lead to a skipping of an exon. This was further confirmed by other splice site prediction tools such as HSL donor slide matrix and MaxENT, which also predicted the same result, that this kind of 5' donor splice mutation, which can result in the loss of a particular skipping of an exon. To analyze this further, we have collected peripheral blood from the parents as well as the 4 children. We have isolated the RNA and synthesized cDNA to perform a PCR, wherein we have used specific primers which are covering the entire region and also the mutation. So we expected a band corresponding to 344 base pair, that is of the wild type CEP57 transcript. Herein, upon the gel electrophoresis, we have seen that since the child 3 of the family did not have any mutation, it only produced a single band corresponding to the wild type transcript equivalent to 344 base pair. However, the parents as well as the child 1 However, the parents and the child 1 here have produced 2 bands, one corresponding herein the parents as well as the child 1 were identified as carriers of this particular mutation and have given 2 different bands, one corresponding to the normal wild type transcript, that is 354 base pair here, and other there is a smaller abnormal transcript produced in the parents as well as the carriers. In the probands, that is the child 2 and the child 4 for this family 1, we have seen a single band corresponding to 164 base pair, signifying that yes, it is a mutated abnormal transcript that is produced in the chromax as a result of this mutation. So we have cut this specific wild type and this mutated band and further performed Sanger sequencing to look upon what is happening in these cases. So upon Sanger sequencing, as we can see here, that in the wild type transcript, there is a full 344 base pair product form having exon 2, 3, and 4 sequences. However, in the mutated CEP57 transcript, there is a skipping of a complete skipping of exon 3 corresponding to 180 base pair sequence, which is not present in the mutated CEP57 transcript. So next we have also done the chromatogram analysis, which have further reconfirmed our findings that yes, when we have compared the wild type transcript with the mutated transcript, there is a skipping of exon 3 corresponding to that 180 base pair sequence, which is present in the wild type transcript but absent in the mutated transcript. This is the model for this particular case studies, that upon a mutation in the 5' splice site in the intron 3, now this splice donor of intron 2 recognizes the acceptor site at the end of the intron 3 due to a mutation in the intron's 3' splice site, donor splice site, which has further led to skipping of an exon, that is exon 3, thereby producing a small abnormal mutated transcript instead of the normal wild type corresponding to 344 base pair. We have also studied the expression for the wild type transcript in the parents as well as the 4 children. We have used specific primers for exon 2 to exon 3 to amplify this particular fragment of 222 base pair. As we can see here, the child 3 had shown significantly higher expression for the wild type transcript as compared to other members of the family. The child 2 and child 4, since they were the programs harboring this kind of mutation, showed minimal expression for this wild type transcript. The parents along with the child 1, since they were carriers of this mutation, have shown some expression for this wild type transcript.
So for family 2, case 3, we knew that there is the exonic deletion from exon 5 to 8. So in order to validate the same, we designed 2 sets of primers. The first set of primer was designed outside the deletion, which is on exon 4 and exon 9, and it would yield us a product of 600 base pair upon PCR amplification. But in case the deletion is present, it will yield a product of 165 base pair. The set 2 primers were designed inside the deletion at exon 5 and 8, and this will yield us a product of 400 base pair upon PCR amplification. But if the deletion is present, there will be no product formed. So we found that when we amplified our cDNAs isolated from the RNA of the family along with the healthy control and a negative control, we found that using set 1 primers, we got a 600 base pair product in all the cases, 3 cases, along with the healthy control as the positive one. But there were traces of 165 base pair band in all the 3, with predominant one in the patient sample. So we cut this 165 base pair product and performed the Sanger sequencing to confirm the deletion. For set 2 primers, we again performed the same thing, did a PCR amplification and found a 400 base pair product in the parents, but it was absent in the patient. And in order to confirm that the rest of the transcript is fine and there is no other underlying mutation, we amplified it through E2 and E4 primers used in our previous case and found that there was a normal product of 344 base pair present in all the cases. So we confirmed the Sanger sequencing of 165 base pair product, and we found that there was a deletion of exon 5 to 8 in all the 3 cases. And as you can see in the wild type transcript, we should get a full length transcript of 600 base pair, but we got a mutated CEP57 transcript with a deletion in the 165 base pair from exon number 5 to 8. So we also did a real-time quantitative PCR to check the expression of the CEP57 transcript in all the across the family along with the healthy control, and we found that there was 50% lesser expression of the gene in the family with respect to the healthy control, and no significant difference in the expression was there amongst the parents and the patient. So further after this, the structural modeling was performed by Dr. Ithayatullah from Biophysics.
Good afternoon, everybody. So in order to see the effect of the mutation on the SF57 protein, we did a structural modeling of the wild type and the mutant protein. So if you see here, SF57 is a 500 amino acid protein, where you see this is the N-terminal domain, this is in the green color, which has a helical-like, long helical-like loop. And you have a C-terminal domain, which is a long helical-like. So these two are linked by a linker region. Why this structure is required? This structure is required to form a spindle-like structure. So this, if you see here, this is a prophase and this is a metaphase state which is occurring in the PCM complex, the microtubules. So with this CEP57 interacts with this kinetochore complex to form a spindle-like structure where the N-terminal domain interacts with this complex, the C-terminal domain interacts here in the prophase complex. Whereas in the metaphase, this CEP57 interacts with this kinetochore complex and interacts with this mitotubules. So this interaction is required for the PCM complex to be stable so that the equal distribution of the micro can happen. So in case of the deletion, what happens is that this internal, the whole internal region gets deleted. As a result, you see a bundle of helices. Here you see the bundle of internal helices and the bundle of C-terminal helices. Because of this one, the flexibility which is required for the spindle formation is lost. As a result, these microtubules cannot attach, this CEP57 cannot attach to the microtubules. Hence, there is a non-functional protein which has been formed. As a result, there is an unusual distribution of the microtubules.
Thank you, sir. So, coming on to the clinical and genetic landscape of the MVAs, we see that all of the MVAs have a common finding of growth retardation and microcephaly, with a pattern of dysmorphism that is seen in MVA type 1 and type 2, which was also seen in our cases. Cardiac findings in form of septal defects and aortic regurgitation have been described till now in about 7 of the 13 cases of MVA2, which was not present in our case. All of these patients usually have developmental delay. In our cohort as well, we found that the children had mild to moderate developmental delay. The novel finding in our patients was that they had Arnold-Chiari malformation and encephalocele, which was seen in case 2. And there was absence of ossification of multiple areas of the occipital bone, which was seen in the family 1, case 2. Risk of neoplasm is described in MVA type 1 and type 3. However, it has not yet been described in MVA type 2. All of our cases are being followed up for their development of any neurological findings. And because growth hormone is currently not recommended in cases of MVA type 2, so it was not offered in our cases, and the levels were also found to be normal. So the mutation spectrum of MVA type 2 has not yet identified any particular hotspot in these in the CEP57 gene. It is described across most of the exons. This 11 base pair duplication has been described in 11 of the 13 cases that have been reported till now in either homozygous state or a heterozygous state. The variants found in our patients were novel and have not yet been described.
So with this, we end our presentation with the take-home messages that we are living in the era of NGS, and NGS helps us in ending the diagnostic odyssey. It also helps in finding addition of novel genotypic and the phenotypic findings to the previously described cases. And it is important to conduct NGS in such cases because it helps in diagnosis of hyper-rare syndrome. The definition of hyper-rare is not known, but the prevalence of MVA is 1 in 10 lakhs. So it is as rare as that. And one should be mindful that there can be intrafamilial and interfamilial variability within the same gene because of the same gene. And deep phenotyping is essential before giving the results to the family. So we have to start from the patient, analyze, do the genomic analysis, and go back to the patient to confirm those genomic findings. And it is very much important to do the functional analysis, especially for the novel variants, because we know that these families can come up again for prenatal diagnosis. And without having that functional validation for novel variants, it may not be uh, uh, correct to offer this, because these variants, the label, the pathogenicity of variants changes over a period of time depending upon the availability in the literature. So genetic diagnosis helps in prenatal diagnosis and counseling, as we hope for this family, because only one child was affected in, there was one child only in one family. They can plan pregnancy further. And it is very important to have an institute like ours to have such interdepartmental collaboration for validating these genomic findings. So next slide. So with this, I would like to acknowledge this was a work which was done under the by Dr. Nitika as a part of her PhD thesis, AIIMS Institute grant, and grant by DBT, which was given to Dr. Chet. Thank you very much. So, if there are any comments from Dr. Chet, how's it open? Thank you.
So, respected esteemed colleagues and dear students, so now our Gynae Unit 1 will be presenting the CCR and will be the topic all of you have seen. So, double jeopardy and how clinical compound, fantastic factor in double jeopardy, just the fancy name. So, let's see how this factor will help. So, Dr. Ayushi, our senior agent, will present the case and Dr. Anju will discuss. And of course, we'll take help from ma'ams and Dr. Chakas. Thank you. The hematology department also.
Good afternoon, everyone. I'll be discussing a case of Mrs. X, 28-year-old, gravida 3, previous to abortion. This was a spontaneous planned conception out of a non-consanguineous marriage. Both partners were Anglo-Indian. They presented to us at 21 weeks of POG. First trimester, patient has initial ANC visits at a private hospital, which was uneventful. She came to us at 21 weeks and we took a detailed obstetric history. In her first pregnancy, that was in 2021, it was a spontaneous conception. Ultrasound finding shows a missed abortion at 9 weeks. There was DNC done, after which there is history of excessive bleeding and she has received 7 units of FFP. After evaluation, she was readmitted 15 days in view of persistent bleeding per vagina and was managed conservatively. She was admitted in AIIMS only, and under extensive evaluation of her bleeding, hematological evaluation confirmed it to be a case of von Willebrand disease. Her second pregnancy was in 2022. It was also a spontaneous conception, and USG shows no GSAC, and beta HCG was on a decreasing trend, and she was admitted outside, managed conservatively, and received 2 fresh frozen plasmas, and had received second FFP. In second FFP, she had a reaction. Third pregnancy was a present pregnancy and a spontaneous conception. Her menstrual history, she attained menarche at the age of 13 years, and her all cycles were regular of every 28 days and lasting for 5 to 6 days, using 3 to 4 pads per day. There was no history of any excessive bleeding, no history of any passage of clots or flooding episodes. In her past history, as such, she doesn't have any history of any surgeries, no history of any excessive bleeding, any post tooth extraction, or any easy bruisability. Her family history was taken, and she doesn't have any documents available, but it gives a verbal finding of father being affected with hemophilia A and one's brother also affected with hemophilia A, cousin brother. In her present second trimester, she felt quickening was felt in 5 months period of gestation. There was a regular intake of iron and calcium, and second trimester was uneventful with no bleeding events. In third trimester, till 36 weeks period of gestation, it was uneventful, but she has a history of fever, which was 100 to 101 degree Fahrenheit with history of joint pains, and she was diagnosed with dengue fever. In her hospital admission, it was a dilemma. As she was a case of von Willebrand disease with the platelet count decreasing, she was admitted with us. Her antenatal investigations were normal, and on her previous investigations, she by von Willebrand antigen level, erythrocytin factor activity, and the ratios, she was diagnosed to be a von Willebrand disease. In her hospital course at 36 weeks, we have a dilemma that she has a dengue fever. She is a known case of von Willebrand disease, and how to go about with the pregnancy, maternal care, and fetal surveillance. For dengue fever, we were monitoring her signs of bleeding, and serial platelet count was done, temperature charting, and input-output charting was done. For her von Willebrand disease, a thorough hematological review and a blood bank team was involved regarding the need for any transfusions. Single donor platelets were screened, and factor 8 was arranged for the patient under JSSK. Fetal surveillance was done by daily fetal monitoring count and fetal growth. NST manning was done for the patient. Our preparedness was maternal counseling and monitoring, adequate blood donation, and adequate blood was arranged. Fetal monitoring was done, and factor 8 was arranged for the patient. She was discharged in a stable condition with a platelet count of 1 lakh. On exam, she then again came to us at 38 weeks period of gestation in labor. Her general condition was good. There was no history of no pallor, icterus, cyanosis, clubbing, edema, or lymphadenopathy. Her vitals were stable. Bilateral chest was air entry was equal and no added sound, and normal S1, S2 was heard. On per abdomen examination, uterus was term size, cephalic, mild contraction was felt, and FHS was 150 beats per minute, and Leica seems to be adequate. On per vaginal examination, cervix was soft central, os was 1 centimeter dilated, 30-40% effaced, membrane was present, and pelvis was adequate. So decision of normal vaginal delivery was taken. Challenges and dilemma in our care was the falling platelet trend, history of dengue fever, what is the mode of delivery, and monitoring of the mother during delivery and postpartum. As her platelet count, platelet trends was being monitored in dengue fever, she had a her platelet count was dropped to 50,000, which gradually on monitoring for 1 week, it came out to be it was monitored and it become 1 lakh. And she came to us in labor. At that time, her platelet count was 1 lakh. But during the labor, on serial trend, it was seen that, and postpartum also, the platelet count was decreasing, and it came out to be 13,000 when she was in labor. She was fully dilated and fully effaced. A multidisciplinary team management was done, obstetrician with the collaboration of obstetrician, hematologist, neonatologist, anesthesiologist, and blood bank. Our preparedness was to arrange adequate blood products, SDP screening and donation, cryoprecipitates to be arranged, intermediate purity factor 8 concentrate to be arranged, adequate analgesia, ICU backup, and prevention of excessive blood loss by our PPH kit and oxytocin were considered. Continuous fetal monitoring was done. As our prior consultation with hematologist, we have planned the patient to give factor 8 prior only, but as she came in labor, we have given her 50 international unit per kg immunate as a loading dose, and a maintenance dose of 25 international unit per kg 12 hourly for 5 to 7 days post delivery was considered. Total of 102 vials were indented, and an estimated cost of 4 lakhs was made. As she was progressing well, but she was taken up for emergency LSCS in view of deep transverse arrest. As her platelet count was 13,000, a decision of general anesthesia was taken. In mild PPH was noted intraoperatively, which was managed medically. Injection tranexamic acid was given to control the PPH, and with a decision of continuing tranexamic acid for 5 days was taken. She received 6 units of RDP and 1 unit of SDP intraoperatively, as this was provided by hematology department. She delivered a male baby of 3 kgs with an APGAR of 1 and 8. In her post-operative course, she had a hematuria on post of day 1, for which tranexamic acid was withheld, and she was transfused with 1 unit SDP and 6 unit RTPs. Injection immunate was continued, that was according to her weight, which was calculated to be 1600 international unit BD for 5 days, and IV antibiotics was considered in view of multiple PVs and excessive blood transfusion. Now Dr. Anju will continue with the discussion.
So thank you, Ayushi. Good afternoon, everyone. So our patient was a pregnant patient with von Willebrand disease. Von Willebrand disease is the commonest inherited bleeding disorder with an estimated prevalence of 1% among general population. It is due to the qualitative or quantitative defect in the von Willebrand factor, which is a large glycoprotein required for platelet adhesion and stabilization of factor 8. It has 3 types, and type 1 and 2 are mainly inherited as autosomal dominant, and type 3 with subtype type 2n as autosomal recessive. So mainly the von Willebrand factor has a role in both the primary and the secondary clotting pathway for the platelet adhesion, which is the first step in the formation of blood clot. And secondly, it helps in the stabilization of factor 8, which is essential for the formation of thrombin, the enzyme that converts fibrinogen to fibrin, the main component of a blood clot. So in our patient, she was diagnosed after a history of surgical evacuation. She has excessive bleeding. So for diagnosis, we had a dilemma since she has a family history of hemophilia also. But the points which favored her diagnosis that she was a female patient, and she did not have any history of spontaneous bleeding prior. So for the diagnosis of this von Willebrand disease, there are certain specific tests, which include von Willebrand factor antigen and its activity by ristosentin test, and we can see the factor 8 level, which are usually normal. So type 1 and type 2 disease can be differentiated by the ratio of the ristosentin level and the antigen level, which are more than 0.6 in type 1 and less than 0.6 in type 2. Type 3 is a severe form, which usually have very low level of this antigen. So when she came to us for in the antenatal period, she was already diagnosed. So in the there are certain points which are to be looked when these patients come to us. In the antepartum period, they usually they have an uneventful course and there are no need of hemostatic agent. Though during antenatal only at the term we prepare for the labor and delivery, since these patients are at a very high risk of PPH, which is a very important cause of maternal morbidity and mortality. So in our patient also, we have done all the preparation with a multidisciplinary team involvement and the adequate arrangement of blood and blood products. One more important thing is that in the postpartum also, since the level of this von Willebrand factor decreases, so we have to closely monitor our patient and for any bleeding events. So the treatment option available for these patients are for the PPH and all, we can give tranexamic acid, and the other factors are desmopressin, which can be given IV or intranasally. And among the blood products, we have cryoprecipitate, single donor or random donor platelets. And in our case, the factor 8 has a pivotal role, which is available in the form of immunate. So this intermediate purity factor 8 concentrate has a factor 8 250 international unit and von Willebrand factor 190 unit. For our patient, since she was pregnant, we indented this under JSSK, and the cost was significant. So in the peripheral centers, when it is not available, the other options are cryoprecipitate, which can be arranged. Cryoprecipitate contain factor 8, von Willebrand factor, factor 13, fibronectin, and fibrinogen. The only disadvantage is that the large quantity of the cryoprecipitate is required, and it involves the risk of transmission of infection. So when we reviewed the literature, there are a number of case reports with pregnancy and von Willebrand disease. Most of the case report, the antenatal course has been uneventful, and most of the patient having excessive bleeding after the delivery in the form of primary or secondary PPH. The one case report by Rashmi et al., which is from India, this patient has an uneventful antenatal course and the delivery, but she presented on post-op day 19 with heavy bleeding. And at that time, she was evaluated with all the tests, and she was diagnosed as a case of von Willebrand disease, and she was managed medically with vitamin K injection, ethamsalate, tranexamic acid, FFP, and cryoprecipitate. So, and she recovered well. There are a number of retrospective studies which have documented the patient with the von Willebrand disease, and the outcome measure in all these study is PPH. So that is a significant factor. So, and they have reinforced that not only the primary PPH, secondary PPH is also very important, and we have to monitor these patients. In a systematic review by McMurray et al., they have two systematic review. In one, they have documented the finding of type 2 von Willebrand disease in pregnancy, in which they included 32 pregnancy in 27 women. The incidence of primary PPH was 45% and secondary PPH was 46%. And they all have, in most of the pregnancy, 96% patient has thrombocytopenia. So they have concluded that the pregnancy morbidity can be because of thrombocytopenia and this deficiency of the von Willebrand factor. So we have to take all the measures to prevent the postpartum hemorrhage, and we have to be available. The readiness for the blood products and other factor has to be made. So regarding the evidence and the guidelines, in the literature, there are no studies comparing the different modalities, like comparing tranexamic acid versus immunate as a randomized trial. So most of the evidence is based on the basis of very low quality and based on the retrospective study and the case control studies. So the take-home messages from our case is, as in our patient, the diagnosis of von Willebrand was made after an event of surgical evacuation. So if any female presenting with excessive bleeding after delivery or evacuation, we have to look for the inherited bleeding disorders like von Willebrand disease and hemophilia. And since PPH is a major concern in these patients, which is a main cause of obstetric morbidity and mortality, we have to do the timely preparedness, and we have to make a effective use of blood and blood products. We should involve the multidisciplinary team and timely consultation with the hematology and blood bank team, so that all the things are ready on time. And as in our case, this factor 8 concentrate had a very important role. So I would like to thank the seniors in our department, our Unit 1 team, the hematology, Dr. Mukul, anesthesia team, Dr. Amit, neonatology team, and the transfusion team, Dr. Hem Pandey, who helped us in ready awareness of lot of blood products. So now I would like to invite Dr. Mukul to give the expert comments on this.
Bleeding disorders, whenever they present during pregnancy or for any surgery, they propose a very significant hemostatic challenge. Like in this case, there are many things to highlight. her father was diagnosed as hemophilia. When a female says that the father had hemophilia, your mind should think that something is wrong. So there are many possible things to explain such a scenario. Father was not ready to come for testing either. What we postulate that possibly father was getting some kind of factors, factor 8 probably, which had VWF and was able to stop bleeding in him on an SOS basis. Then to convince her that this is not hemophilia, this is something else, and some of the testing were to be outsourced. So that was another point to consider in such a scenario. One of the interesting thing is that bond factor assays, they are not easily available. So we at AIIMS are doing antigen level. For other specialty tests like restoration, they are to be outsourced, unfortunately. And now there is emerging literature that these tests are to be performed each time whenever you are performing any hemostatic challenge for any surgery, and suppose this patient plans a subsequent pregnancy, then again these levels are to be checked again, because these levels tend to vary with time in a particular patient as well. Third thing is about the factor which we give, the treatment which we give. So as has been highlighted that three types of von Willebrand disease is there. So type 1 is when there is a quantitative defect. Type 3 is also a quantitative, severe quantitative defect. And type 2 is a functional defect. So in type 1, the additional treatment in the form of desmopressin, cryopressate, precipitate can suffice for majority of the patients during minor surgeries. But for major surgery, you will require factor concentrates. For type 2, which is what the likely diagnosis in this case, since the body is producing a non-functional product, so any form of desmopressin is not likely to help. These patients will require some kind of factor concentrate. Now, lastly, coming about various factor concentrates which are available. So we normally think that whatever factor which we give should have a high purity kind of a thing. So high purity factor concentrate or recombinant concentrate, factor 8 are now readily available in market. Unfortunately, these do not contain enough amount of one relevant factor. So when we say high purity factor 8 concentrate or recombinant factor 8 concentrate, they have negligible amount of VWF. So these products are to be avoided in our patient diagnosed with VWD. For such patients, we go back to our old plasma-derived intermediate factor 8 purity concentrates. So this is to be remembered. New thing about is that recombinant VWF factor is now available worldwide, but not yet available in India at present. So overall, if we see there are multiple things which are to be considered, the surgery, the pregnancy or a surgery is to be planned in a very diligent way. Factor 8, we usually monitor these patients with the VWF levels, factor 8 levels, and restocytin cofactor assay, which are to maintain above 50% during first 1 or 2 during the peri-op period, and subsequently maintain for around 5 to 7 days for major surgery. For minor surgery, at least for 5 days. So multiple issues which come up, monitoring the turnaround time of test is not very economical, not easily, even for the outsourced, the reports come within a week time. So these are certain difficulties which we face. And if at all the factor 8 levels, which can go very high, if they go above 150%, these bleeding diastasis patients are at risk of thrombosis as well. It further complicates all the things. So, thank you, Dr. Anju, for the slides. I'd like to answer any questions, comments.
Looking at the pedigree, it was mentioned as hemophilia. When we have a family history, then we have molecular diagnosis first, followed by any other further testing. I'm not sure what was the molecular diagnosis in this case.
In this particular case,
in
the family members.
So family members, whether they were tested or not, because
that's why I explained it initially also. The family members were just not ready to come. So what we postulate is that the father were getting SOS factors for bleeding episodes. So what he might have been receiving was intermediate purity factor 8 concentrate, which is able to stop bleeding.
Second, you said that whenever surgery is planned, then these factors should be done. Is APTT not sufficient?
So APTT and PT, they are useful to an extent when the factor activity is, they get derailed when the factor activity goes below 20%. So above 20 or 40%, APDT tends to be normal. So it's not a very reliable marker for monitoring during the perioperative period. Can be used as a screening marker many a time, but not for perioperative management in a diagnosis.
Baby test.
Huh?
The baby test.
I don't think it was.
It was genetic department, no? And they are sitting.
Ma'am,
Then patient did not come. The genetic testing is not confirmed.
pediatricians is it is told that VWF factor they increase during pregnancy, and most of the patients during with type 1 they don't require any factor VIII concentrate support during the peripartum period, but the levels falls within few days, so that's why they tend to present more with secondary PPH rather than primary.
She had double Jeopardy, no? 10 plus no platelet. Yeah. We have forgotten the second Jeopardy.
So, sir, no, when we look at the chart of this patient, the dengue was the history of dengue was slightly prior to the delivery time. So by that time, we anticipate that the platelet count should have returned to normal, like in this case which we saw. But the platelet count coming down to around 30,000, that raises a lot of doubt. That was a problem area which is difficult to explain. Fortunately, when Dr. Andrew said that our team gave the SDP, what it meant was that one of our patients' SDP was expiring at that time, and we were able to support at that time. So that was something which happened in an emergency. So to explain that 30,000 platelet count on day of delivery is difficult on my part.
And for this patient, we had arranged the SDP, but she delivered in the emergency hour. She had an emergency cesarean section in the night at 2 a.m., 3 a.m. So we had requested the hematology department and we could get the SDP of the other patient. And then her SDP we gave in the postpartum period. And then platelet count gradually increased.
Post-op platelet recovery was almost on day 3, it was nearly normal, so more than 1 lakh. Those kind of responses, reports, we're not able to explain very well. Why the platelet count fell down so low on the day of delivery when dengue was happening around 2 weeks prior. We don't anticipate such kind of a natural course with dengue.
I would like to request Dr. Devi Sharma to make this.
And we thank and scientists also because taking such case with low platelets and taking get to this patient, so the minimum positive is required to be managed. The levels are low, with the risk of hypertension. That was very there is being very sparingly for to save our. We are thankful to them and of course the getting and even it was this part because we are thankful to them also.
And Dr. Haim also got stuff.
Yeah. So, but we are really thankful to really getting the success of it. And child was the women menstrual cycle. So they come and coming to us, even at adolescent. It's unlike that they have obstetrics or bleeding gums or bleeding correct. Mostly they have heavy menstruation. So from the very beginning, 13, 14 years, we start seeing big patients. And then in most patients will ultimately have get married, they will have pregnancy, then they come to us. So we end up getting the patient. We recently, last year, we did a CN on from West Year. And then great difficulty, we could close that down. Again, the agent we had to reopen her. They were really problems. So that would be thankful. They gave us better 7, which is even more expensive, I think 7, 8 lakh. So I got a recent actor from UCMS. They got better 7 lakh. So she didn't mistake. But costing 7, 8 lakh rupees, and then nobody is trying to like your then I had to charge her because we couldn't arrange that much. So this is the problem for
So, sir, for such rare disorders, wherein you have factor 7 deficiency, so there is a rare disease policy where it can be applied for, but obviously it will not be available on immediate basis. because of the procurement
So
and
please tell
other
us, because
issues.
that poor lady had
So that's
to
why
charge
I-
her and then they said that
Maybe
BPL
those-
card and she got BPL also.
For any if factor 7
Factor
rare
seven.
genetic
Swati
conditions,
Tomer,
rare genetic
You
conditions.
meet Matt, please, I want to operate that lady. Thank you. Yeah.
That's one query. But he recently moved out homophilia in this family because there is a pedigree which looks like X-ray. Father has a history, and maybe we haven't tested. HIV,
Female and male.
Male.
But
Ma'am,
in this case, we thought that she also had hemophilia, maybe, like.
Because carriers can manifest.
Ma'am, carriers can manifest, but they
For
won't have.
manifest carrier also we have a assay which is
Yes.
available in our lab. So that can also be done. So we actually need to exclude whether there is a manifest carrier or BWF.
Am I?
You should have taken madam's opinion. Genetic वालों को जरूर दिखाओ. नहीं.
Actually, the patient
Ma'am,
came at
most likely.
21 weeks and she had previous to abortion. So at this time, she was not willing for any of the invasive testing. So that's why. But we want them to
At least for the child,
genetic
we
testing.
should see that.
And for the child, we should rule out both hemophilia and VW in such a scenario because most of these cases are autosomal dominant only, likely to be carried out. Yes, yes.
I think round they come with take you also. One, two, three. Many of these patients have, the platelet that move to right. Let's see many patients now.
It's good that we appreciate and we have enough time to ask you to do nothing to do with the debate. It's very long. It's been for so long that all moved up. We didn't have genuine questions and genuine topics today. We take care of what we will see. How much of a there is might have a little small detail might have a large. The only thing for people to remember is that there is something called palpable purpura, which is associated with gastritis. But if your bleed is large enough, it can be palpable. It's not just palpability, but if it's inflammatory purpura, then it's true gastritis. If it's non-inflammatory, then it's true.
Sometimes the level of treatment, like less than 50% have to be AIDS and also.
So if you have somebody who is graded down in a station, it's already sure.
When the patient's restrictive activity it came out to be very low, that was the clinching diagnosis for us. So,
Disorders also theoretically speaking.
so we had a very difficult time convincing her that this is your disease is not hemophilia.
But then that's for complete.
Our veterinary medicine department you want to say something?
Is 1 milligram factor actually enough to diagnose? We have to go for this.
So three things are essential for diagnosis. 1 milligram antigen level that is low in type 1 and type 3. For diagnosis of type 1, you need a functional assay that is done with this restoration cofactor assay and volume ratio. So when this this is a functional assay. So when this activity is also low, when the antigen is low, activity will be decreased. But when the ratio becomes less than 0.6, then that time you can diagnose that as type 2 1 disease. So type 2 also has 4 subtypes. Subtyping testing is it's a kind of a research tool and not easily available. So that typing we are not doing. Since it's a carrier for factor 8, so factor 8 levels go down in type 1, they are undetectable in type 3, and there is specific subtype type M, 2M, in which also factor 8 levels are very low. So these three things are required for diagnosis.